Hi, my name is Sruti. I'm an M4 at UNMC. I'll be presenting our pet bird's a risky move, an unusual case of refractory dyspnea. So my patient's story starts on the left there. She's a 51-year-old female and she'd been having shortness of breath for a few months. She went to her doctor after her pulse ox was down in the 80s and her PCP ordered an echo, which returned normal. He then suspected adult onset asthma, and so she had PFTs done, which were inconsistent with her diagnosis. It actually showed more of a restricted pattern with reductions in FEV1 and FVC with the normal ratio. But then her shortness of breath started to worsen. She had a really bad episode where her pulse ox went down to the 60s, and she went to our ER. In our ER, she didn't have any new complaints. A dry cough and shortness of breath was all, and a review of systems was relatively unremarkable. In our ER, her vitals were normal other than her O2 sats, so she was down in the 80s with exertion, placed on 2 liters nasal cannula, and then went up to about 98%. Physical exam didn't show very much. Her lungs were clear to auscultation bilaterally, and there were really no appreciable findings. In the ER, our patient had a CBC, a CAP, an EKG. She also had a CHF peptide, a VBG, a CRP, and a COVID test, and a respiratory pathogen panel. And all of these results were actually negative or unremarkable. Our patient also had some imaging done in the ED. She had a chest x-ray, which was normal, but she also had a CT scan, which showed bilateral ground glass opacities seen in her scan in the top right, and also tree and bud nodules, again in her scan on the bottom right there. At this point, our patient was transferred to the floor for further workup, so I'd like to offer a flowchart that kind of goes through a way to work up dyspnea, since I know a lot of different etiologies come to mind. For our patient, I highlighted our workup in blue. So starting at the top there, since our patient had been having symptoms for over 3 months, we kind of go over to the chronic side. And then from there, we start from basic initial lab testing or tier 1 testing. So the idea behind tier 1 is to just evaluate for the most common causes of shortness of breath, including asthma, COPD, interstitial lung disease, myocardial dysfunction, and obesity. Her PFTs, of course, were remarkable for a restrictive disease. And then we go down to tier 2, which most had been done in the ED. The most remarkable finding, of course, was her CT scan, which I discussed on the previous slide. And that brings us to tier 3, which is kind of where she was when she came up to the floor. So she had a bronchoscopy done that showed basically things that were pretty consistent with her CT, but was otherwise normal. The lavage, however, that accompanied her bronchoscopy was cultured and was negative for acid-fast bacilli, Legionella, Aspergillus, CMV, EBV, HSV, and HHV6. The cytology workup from this lavage showed significant lymphocytosis up to about 80%. At this point, we decided to kind of review the patient history because we didn't have a ton to work on other than the PFTs and her CT scan. So the patient mentioned that she had actually been living with cockatiel birds for the past 5 years. We got a hypersensitivity panel and she ended up having positive antibodies against bird serum. I would like to take a second to go through the criteria for this disease. So for 1, our patient had a known exposure to cockatiel birds. 2, she had compatible clinical, radiological, and physiological findings. 3, she had a lavage with significant lymphocytosis. We didn't do anything with positive inhalation challenge testing, and we didn't collect any histopathology. But you don't need to fulfill all 5 criteria to get this diagnosis. So looking at that black box on the right, I've color-coded things to match the left, and she technically fulfills 1, 2, and 3, and so she received a definitive diagnosis in this case. So something interesting about this disease epidemiologically is that it's relatively very rare. So the prevalence overall ranges from 1.67 to 2.71, so not very much at all. And specifically for bird fancier disease, which is what our patient had, the prevalence is less than 0.2%. Additionally, I'd just like to take a second to discuss the pathophys, which is in fact very complicated. But the general overview behind this disease is that there's an antigen stimulus that causes some kind of host reaction, and it's an interplay between these two things repeatedly over time that can kind of cause chronic disease and fibrosis down the line. So looking over the treatment plan for our patient was actually pretty stable throughout her hospital course. So she was eventually discharged with 3 liters of oxygen and was advised to avoid, spending time with her birds and making sure to clean her house. Follow-up 1 week later revealed a significant improvement in her clinical symptoms, and 1 month later, she had no oxygen needs and had significant improvement in her CT scan findings. So those findings I've shown in the bottom left there on admission compared to where she is 1 month follow-up. And this is all after getting rid of her birds and kind of doing a deep clean of her house. In general, the treatment for this disease is, of course, avoiding antigens and then offering supportive care. But second line, we usually think about steroids, and third line, in cases of severe fibrosis or persistent symptoms, is lung transplantation, unfortunately. So I just found this case to be really interesting because in this case, this patient's dyspnea was actually indicative of a really rare pulmonary disease, and I had just never encountered hypersensitivity pneumonitis before. I also just want to offer some very brief take-home points. So one of which is that it's really important to consider social history when looking at the etiology of dyspnea, because in this case it was pretty crucial. 2, diagnosis of this disease involves a process of exclusion and involves a careful dyspnea workup. 3, this disease has a really low prevalence rate, and the pathophysiology behind it involves a pretty complex immunologic response. And last, the management of this disease primarily involves antigen exposure, but can also, go up to include glucocorticoids and possibly lung transplantation. Here are a list of my references. I just want to take a second to offer my sincere thanks to Dr. Topolsky and Dr. Anderson, who were a big help in putting this together. Thank you all for coming to my virtual poster presentation. I'd be happy to take any questions anyone has at this time.